Pediatric Emergencies Part 10. In this final lecture, we're going to be discussing the pathophysiology, assessment, and management of pediatric traumatic emergencies. Children's age-related anatomy and physiology make their injury patterns and responses to trauma different from those seen in adults. The developmental age will affect response to the injury. For a young child, being strapped to a backboard, for instance, may be as traumatic as the injury leading to the EMS call. Blunt trauma is a mechanism of injury in most pediatric injury cases. Children have less muscle and fat mass than adults, which leads to less protection against the forces transmitted in blunt trauma. Falls are also very common. The injuries will reflect the child's anatomy. Falls from a standing position usually result in isolated long bone injuries. High-energy falls result in multi-system trauma. Injuries from bicycle handlebars typically produce intra-abdominal compression injuries. Motor vehicle crashes can result in a variety of injury patterns depending on restraints and position in the car. For unrestrained passengers, assume multi-system trauma. Restrained passengers may sustain chest and abdominal injuries associated with seatbelt use. Suspect spinal fractures with chest or abdominal bruising in a seatbelt pattern. Airbags can cause head and neck injuries in young children. Multi-system trauma is likely with vehicle-pedestrian collisions. Chest, abdominal, and lower extremity injuries occur on impact. Head and neck injuries may result from the fall when the child is thrown. For assessment and management of traumatic injuries, your first steps are the same as for medical emergencies. Begin with a thorough scene size-up. Look for safety concerns. Determine your mechanism of injury. Use your pediatric assessment triangle to form your general impression and make sure that you are initiating life support interventions for any life-threatening illnesses or injuries found. You should assess the airway for obstruction with teeth, blood, vomit, or edema. Have suction available. For cervical spinal injury, you should open the airway with a jaw thrust maneuver. If the child cannot maintain the airway, consider an NG or pharyngeal airway. If you attempt ET intubation, maintain cervical spinal precautions. The establishment of emergency surgical airways in a child have several complications and a high failure rate. Breathing assessment includes evaluation for symmetric chest rise and equal breath sounds. Pneumothorax may be present with penetrating trauma of the chest or upper abdomen. It's not common in pediatric blunt chest injury, but you may see it. JVD and tracheal deviations less likely in a child. If the MOI suggests a possible tension pneumothorax and child is in significant respiratory distress, you should perform a needle decompression. Signs and symptoms of tension pneumothorax include tachycardia, difficult ventilation despite an open airway, absent or decreased breath sounds on the affected side, JVD or jugular vein distension, hyperresonance to percussion on the affected side, tracheal deviation away from the affected side, and pulsus paradoxus. This is just an image of performing a chest decompression. Tracheal deviation is a late finding, and tension pneumothorax can be present without it. In order to perform the decompression, you should use a large bore IV catheter, preferably 14 to 16 gauge for these patients. Locate the second or third intercostal space in the midclavicular line on the affected side and insert the needle at a 90-degree angle just superior to the third rib. Any trauma patient should be considered at risk for developing shock. Assess circulation by checking pulse rate, quality, cap refill, skin temperature, and blood pressure. In pediatric patients, the only sign of compensated shock might be an elevated pulse rate. Remember, kids have remarkable capacity for peripheral vasoconstriction and to compensate despite significant injury. If the MOI is concerning and the child is tachycardic, assume compensated shock and initiate volume resuscitation with 20 mL per kilogram isotonic fluid, normal saline or lactated ringers. Once ABCs are stabilized, continue assessment of disability with AVPU. Place cervical collar and immobilize on a long backboard as indicated. If increased intracranial pressure is a concern, keep the head midline to facilitate jugular venous return to the heart. If the child's not in shock, elevate the backboard or head of the stretcher to 30 degrees. Perform shock resuscitation with IV fluids. Brain hypoperfusion will worsen the situation. If the child has acute signs of herniation, such as a blown pupil or Cushing's triad, consider mild hyperventilation guided to an end-tidal CO2 level of 30 to 35, and also mannitol should be considered. Assess exposure by performing a rapid exam to identify all injuries. Log roll the child to examine the back and the buttocks. Cover the child, keep them warm. Treat any fractures as you would in an adult. Some traumas are load and go because of the severe injuries and unstable condition. For these situations, perform your life-saving steps on scene or en route. Transfer quickly per local trauma protocols. All trauma victims with suspected spinal injury do require spinal stabilization. Do not place a collar that is too big on a child. Remember, you should use the appropriate sized equipment for the children. If the patient's stable and does not meet load and go criteria, obtain additional history and perform a more thorough physical exam. A full body, back to front detailed physical exam en route for all trauma patients with significant mechanism of injury. For infants, this includes checking anterior fontanelle for bulging. Also look for bruises, abrasions, other subtle signs of injury that may have been missed. Revisit the primary survey during en route reassessment because with pediatrics, their condition can change quickly. Airway management and ventilatory support take priority over circulation management, but once you have these managed, then you can consider fluid management. Tachycardia is usually the first sign of circulatory compromise in a child. It can also be caused by agitation, being scared, or being restrained. Children are able to compensate for blood loss from any cause, including trauma, so hypotension is a late finding and an ominous finding in pediatric trauma. Once a pediatric patient is hypotensive, they're already in severe trouble. Recognizing circulatory compromise and treating it early are even more important in the pediatric population. Consider the following when establishing vascular access in an injured child. Large bore IV catheter should be inserted into a large peripheral vein. In infants and young children, 20 or 22 gauge IV needles may be considered large bore. Definitive care can only be provided at the ED, so never delay transport to start an IV line. To maintain perfusion, administer initial bolus of 20 mL per kilogram using an isotonic crystalloid solution. Frequently reassess vital signs and provide additional IV fluid boluses of 20 mL per kg if no improvement is noted following the initial bolus. Up to 60 mL per kg can be given for resuscitation of a pediatric patient. If the patient is over 50 kilograms, use adult resuscitation fluid volumes. If the condition does not improve following 2 boluses of an isotonic crystalloid, blood loss is likely severe and the patient may need surgical intervention. Provide rapid transport and continuous monitoring en route. If the child is hypotensive and IV access cannot be obtained within 90 seconds, consider inserting an IO needle. Pain management. Pain is often undertreated in children. There are specific tools that you should use to elicit the child's self-report of the pain level. Always use a calm, reassuring voice. You can also consider distraction techniques and medications when appropriate. Children who are in shock and hemodynamically unstable are not good candidates for narcotics or sedatives. Common use pain medications include morphine and fentanyl. Intubated patients should receive pain medication and sedation, such as diazepam and midazolam, if they're hemodynamically stable. Side effects of narcotics and benzodiazepines include respiratory depression, hypoxemia, bradycardia, and hypotension. Always weigh your benefits and risks of administering. Management of burns. Assessment and management are similar to that of adults with a few key differences. You got to remember there is a skin surface to body mass ratio, which makes them more susceptible to heat and fluid loss. Worrisome patterns of injury or suspicious circumstances should raise concerns of abuse. Scene safety is important for your patient, for you, for your partner. Check for ongoing dangers such as fire, chemicals, or other hazardous materials. Perform a from the doorway assessment, which may identify signs of smoke inhalation. Estimation of the percentage of BSA burn may affect decisions on fluids. For adolescents, use the rule of nines that you use for adults. For younger children, modify the rule to account for disproportionately larger head size. In infants, the head and trunk each account for 18% of the body surface area, the arms are 9%, and the legs are 13.5% each. The size of the child's palm represents about 1% total body surface area. You can use this to assess the extent of the burn. Burns suggestive of abuse include those in which the mechanism or pattern observed does not match history or child's developmental capabilities. For example, a child who cannot stand is unlikely to pull a hot cup of coffee off a table. Splash burns, as from tipping over a pot of boiling water, should have an irregular configuration because the hot liquids run down the child's body. Be suspicious if a burn has clear demarcation lines or is on the buttocks. Remove burning clothing and support your ABCs. With signs of smoke inhalation, consider early intubation. Have a range of tubes available. Airway edema and sloughing may mandate the use of a smaller tube than originally estimated. Give all burn victims 100% supplemental oxygen. Smoke inhalation may also cause bronchospasm, which may result in wheezing and mild respiratory distress. You could consider a bronchodilator such as albuterol or epinephrine IM. If possible, insert an IV line and initiate fluid resuscitation and transport for patients of more than 5% of burned body surface area. You'll start with the 20 ml/kg of isotonic fluids, then reassess the need for additional boluses. Large burns can lead to huge fluid shifts. Although these shifts are usually not seen during the acute or the pre-hospital care time, we can go ahead and plan for these fluid shifts and use things like the consensus formula to determine what fluids we should give. Clean the burned areas minimally, avoid lotions or ointments, cover the burn and patient as needed. Analgesia is a crucial part of management and transport to an appropriate medical facility that can handle burns. Most injuries are preventable. Tracking injury patterns helps target areas for intervention and prevention. As you care for children, you may be frustrated by the illnesses and injuries that you encounter, especially when they are preventable. Take this frustration as a call to action. Get involved in your community, participate in existing prevention programs, or start your own program. Choose something that interests you and take a leadership role. These are examples of common injuries and possible prevention strategies. This concludes Pediatrics Part 10. If you have any questions, please contact me, Nick Ray, at suscc.edu.